It's time to imagine better health with CHI Health. For our guests, it's not just a matter of treating patients, but caring for them.
Yeah, developing technology that's giving patients more time with their families and better quality time, which is what motivates them the most.
And Dr. Brian Loggie is a CHI Health surgical oncologist. Also returning this morning, oncology nurse practitioner Holly Sennett. Thanks for stopping by this morning.
Hi, it's good to have you back.
Thank you.
Good morning.
Doctor, you've been recognized as one of the best doctors in America. I'm not trying to toot your horn, but be honest here. Where'd that designation come from?
From a couple of different places, and I've had that designation since I think 2000, 2001, somewhere around there.
Years ago, you started to look at treatment options for patients with abdominal cancer.
Right.
What was motivating you back then?
Well, that we had no treatment, and so it's very frustrating as a surgeon, surgical oncologist, to have these patients coming in with tumor that had spread all over the lining surface, and for almost all cancers with colon or appendix or small bowel, that's stage 4 disease. And when I started, or stomach even, we had basically no treatment. And so I developed an experimental protocol to operate on these patients, remove the tumors. They always came back after surgery if you didn't do anything else. So we added heated intraperitoneal chemotherapy as a perfusion at the end of surgery. And we're kind of astonished by the results because honestly, based on how patients did before that, we weren't expecting, to see very many one-year survivors. So when we started seeing 1 and 2 and 3 and 5-year survivors,
that's amazing.
And we did it as a formal study for many years. So that was when I was at another place. And when we finished that and did the statistics, we adopted it as a standard of care. And it's something that we've been doing here and also trying to improve.
But you didn't expect this type of outcome when you started working on this. It's called heated chemo, but how does this work? How does it work?
That's the simplest part. It grabs people's attention, it grabs the insurance company's attention, but it's actually the easiest and least expensive and least morbid part of what we do. Once we've finished operating, which is the big deal for me, then I get to relax. We put tubing in for inflow, outflow, close the skin, and then we set up a heated circuit, add chemotherapy to that, and then we run that while we're gently pushing the patient for about an hour, and then we're done.
Wow.
But what it allows us to do is to give chemotherapy, the tumors are exposed to a lot of chemotherapy. In order for them to be exposed to a higher concentration of chemotherapy, you have to take the tumor out and put it in a test tube. So that's the strategy, and it's worked well for both. We operate on patients for curative intent. I don't even know what that means anymore. And for palliative intent, for example, if they got a lot of big fluid buildup. And it works in both situations.
There are a couple of patients that I want to ask you about because I know you've got some stories about the difference in the lives that you are making with this approach. But Holly, I want to talk to you about the quality of life. And that phrase is something we hear sometimes, but this is really the approach that the two of you share. Why is that so important for you in the way that you see your patients?
Well, the quality of life is the most important part. If you damage quality of life, then you aren't giving them any more options. So keeping that in the front of the treatment plan, then you are giving them all sorts of options on the table.
Yeah, for each of you, you have this definition of cure. I guess what are your definitions of a cure?
I struggle with that. I don't actually have a good definition. There's a definition that I give to patients, which you may find a little bit shocking, and that is I tell them if they come in, they've had a big surgery, they've had advanced disease, scans look fine, they're doing fine, they have no evidence of disease. If they walk out of the clinic now and get hit by a bus, they're cured. Because if there's always a risk for recurrence. I used to think that there was a magic number, like 3 years was my magic number for a long time, and there's no magic number if you're dealing with these advanced. I mean, if you talk about skin cancer, you take it out and you're cured. That's easy. But for the patients that we deal with, many of them have advanced or bulky disease, stage 4 disease. There's a risk for recurrence. Some will do well forever, and I guess they're cured, but you have to follow them for a long time to kind of say that.
Do you see patients with all types of cancer? I know we talked about your research and abdominal cancer, but ovarian cancer is another area where you're seeing
We've
lot of
used this
patients.
because the issue with ovarian cancer, I think probably all of your viewers would know somebody who's died with ovarian cancer. And the problem with advanced, we only treat advanced ovarian cancer or recurrent ovarian cancer, but with advanced ovarian cancer, we see very nice responses in probably the majority of patients and surgery, and so they can look free of disease, but the majority are going to recur and die within 5 years. And we've gone back to an old-fashioned approach that has been abandoned largely, and that is we do second looks. But instead of just looking and saying, yes, there's disease, no, there's not disease, the problem is with that is that you're not doing any treatment, and if you say, no, there's no disease, the majority still can recur. And so we go in, if we find disease, we treat it, we add the heated chemo. If we don't find disease, we assume there are cells lurking there, we add the heated chemo. And the reason for that is that we really want to knock the tumor down hard, because if it comes back in a short period of time, it's become resistant to drugs and treatment. If it comes back over a longer period of time, the cells have forgotten the drugs that they got, they're now sensitive again, and it puts all of the treatments back on the table.
Before we run out of time, Holly, is there a story? I know there was one woman in particular she was pretty young, who had some little ones at home. She was married. How were you able to help her?
Well, she was diagnosed with a very rare disease, and she had gotten sent to us on kind of the last ditch effort to help her. And we were able to turn that around with aggressive treatment, but also we preserved her quality of life and kept her going, and she was able to watch her boys grow up to about 7 or 8 years old, and she got quite a few years in with them.
It was either hospice or your office,
Yeah, they
and
were
you
offered
gave her that
hospice or
time.
us.
And they gave
Which isn't
those
much.
years with her family.
Yes.
It's priceless. The website is chihealth.com/abdominal-cancer-surgery. We'll link you back to that as well.
And you're not staying just in the operating room, doctor. You're still continuing with some of the research that you've
Yeah,
been...
it's the research that excites me. And for some of the common diseases that we treat, we've identified some pathways for treatment. Other people have potentially, but we've identified where they fail. And so we're able to trace those pathways back. And now, at least in the laboratory, we're doing very well by blocking these two specific pathways. So I'm hoping we can go to clinical
Very
trials.
assuring
Fortunate
for
to have
patients
you.
out there, yeah.
Have you in Omaha, Dr. Loggie.
Thanks, doctor.
Thank you.
Oh, thank you
Holly,
very
we
much.
Holly,
appreciate
good
your
to see ya.
time. Another